This season of the Breech Birth podcast will be a little different. I'll be speaking with researchers, midwives, and obstetricians working within the breech birth space, bringing additional perspectives, knowledge, and evidence-based research to you, the listener. I hope you enjoy these conversations. Hello, Dr. Rixa Freeze. Welcome to the podcast.
Hi, thank you. Nice to be here.
I'm really, really excited and honored to have you on the podcast, so thank you.
Yeah, I'm super excited to be here. We're recording from halfway around the world. I love the technologies that let us collaborate and communicate like this.
Yes, and so you're in France?
Correct. Yeah, I live in France about 7 months per year, and then in the US about 5 months per year.
Amazing. All right. I've got a heap of questions. So before we do that, would you mind sharing a bit about yourself, your background, who you are?
Sure. So I come from a background in maternity care, childbirth, midwifery, home birth, unassisted birth. In terms of research interests, that's where I grew up in. If you want to talk about my childhood within the birth world, I started researching childbirth as a PhD graduate student when I was looking for a research topic for a class called Feminist Research Methodologies. And I had a colleague who had just had a baby, was wanting a home birth, but couldn't find a home birth midwife. So she had a hospital midwife and had a really negative experience and said she's going to never go back to the hospital again. And I was so intrigued when she said home birth was not legal in our state at the time. And I thought that'll make a really interesting research topic. And I became hooked on childbirth from that point forward. And that quickly led me to changing my focus for my PhD program and knowing that I was going to be looking at birth as a topic and found my academic passion. So I started in the world researching home birth, midwives, unassisted birth, and those sorts of things. And breech was a side interest from nearly the very beginning, although it wasn't a research interest during my PhD years. But after my PhD was finished, I think within a year after I graduated, I was already doing some breech-related research and going to conferences, although it wasn't my predominant full-time interest at that point. I also was having babies. I had 4 children, all born at home. My first was born at home, unassisted on purpose. My last 3, I did have an amazing, very laid-back midwife. Had another unassisted birth with my third when my baby came out very quickly and had to resuscitate that baby myself, which was very interesting. So I've had a couple of very interesting births. I've had lovely births and feel really, really grateful that I came to birth myself in terms of my own experiences giving birth from a very empowering and very positive place. All 4 of my births were really lovely, challenging at parts, but really, really great experiences. That's kind of my background in terms of academics. My PhD program, like I said, focused on maternity care and childbirth. I wrote my dissertation about why women choose unassisted home birth in North America, often called Freebirth over in Australia. And then, like I said, I graduated and started getting more interested in breech, kept abreast of some of the developments in physiologic breech and the amazing collaborations that were happening. And when my youngest was 3, we were living in France at the point, and they have public school starting at age 2.5 to 3. And so I had all 4 children starting school at that point. And if you've ever been a mom and been raising young children and then they go to school, it's this lovely time where you suddenly have lots of free time. And so it was at that point around 2016 that I said, I really want to specialize in breech. I was still very interested in the topic and found myself consistently drawn back to it. And so I decided to sit down and get to know the research really well. Because I said to myself, if I want to specialize in this as an academic topic, I really need to know all of the stuff. And so somewhat naively, I sat down and I said, I'm going to read everything there is. And so I kind of did. Over about a year, I went systematically through PubMed and went through everything that I could find, every hit on breech from the beginning, which is around the mid-1800s to the present, and read through and categorized everything that I found. There was about 4,000 plus research articles that I went through. And that was really interesting because I got a comprehensive look at everything that's been published, at least that's indexed within PubMed, which is most of the medical literature. I'd say nearly everything, and was able to get a big picture view because I was going through everything all at once and just seeing what I was finding and then organizing and categorizing it as I went. And that actually was probably one of the things that led to me founding Breech Without Borders, because I started writing about the things I was finding, and then people would start to ask me to give lectures and travel and give presentations. And one of the places I was asked to travel to was St. Petersburg, Russia, for this midwifery conference. And when I was there, I gave a presentation about breech birth and was referring to the term breech trial, which in Europe, North America, and I suppose the westernized world, as you might say, especially the English-speaking world, everybody knows about that. If they know anything about breech, it's still very much in common parlance, I suppose you'd say. People know about it and talk about it, even if it's in the terms of it's been debunked. And in Russia, they said, "What is this term breech trial? We've never heard of it." I was like, huh, that's interesting. There's knowledge that's not crossing geographical and language borders. And it struck me that there's a lot of information that's just not crossing boundaries. For example, when I was doing this systematic research into PubMed, there were all these techniques with breech birth that were talked about in the Russian literature that never made it into any of the translated literature. And so it remained within Russia and Eastern Europe. So there is one called the Sovyanov technique, and it was widely publicized in Russia. And even now to this day, the textbooks in like Ukraine and Eastern Europe, they all talk about Sovyanov. Have we ever talked about Sovyanov? No, because nobody ever translated him. This sparked an idea. And I remember saying to myself after Russia, I was like, somebody really needs to start an organization where we are helping breach information cross borders. And as things go, that was 2017, and a year rolled around, and that somebody turned into me. And so in 2018, I founded Breech Without Borders as a 501c3 nonprofit or public charity. And I just knew that I wanted to do something with breech. I wanted to advance breech knowledge, education, information, training somehow. And I knew that the first step was to start a nonprofit because that's the way that you can obtain grant funding. And so not really knowing what Breech Without Borders would become at that point when I founded it in mid 2018, I put together a board of directors. We did all the paperwork. We made a website. I started putting information on the website. And things started happening. I got invited to teach some more things, teach some kind of early forms of our breech training workshops in the late part of 2018, where I would do a series of lectures, and then the local person would do the hands-on training. And that's where I met Dr. David Hayes, and we co-taught for many, many years together. And that's what really kind of sparked Breech Without Borders as we know it today in terms of the training model that we developed and the organization that we've become. So that's a little bit of the history of how I got to where I am today and the things that drive me. What really interests me about Breech is that it's a litmus test for the commitment to maternal autonomy, because breech is probably the hardest thing to support in our current maternity care system for a number of reasons. The first is that there's a lack of training and skill and experience. And so we have this vicious cycle of de-skilling and fear and lack of experience, and that makes breech birth less safe. And because it's perceived as less safe, then people don't want to do it. And so it's very, very hard to overcome that. And it's also hard because there's massive pressure to just tell women that their only choice is a cesarean section. And this is a very real pressure. It's not, a small hypothetical. And breech providers who still have the training and expertise have a lot of, a lot of pressure against them within medical systems. This is from some research that I did interviewing American obstetricians who are still offering breech birth within the hospital system. And they face pressure from their peers. They face getting reported for every breech they do and having to go in front of the medical board just by having supported a breech. No bad outcomes. They face breech bans in their hospitals. They face threats of being fired or losing their hospital privileges if they don't force a woman into cesarean section. I mean, this is a pattern that's repeated over and over. So it's very difficult because there's so many challenges to supporting this, both from legal standpoints, from financial standpoints, from training standpoints, malpractice, insurance standpoints, all these things. There's a lot of challenges that we have to overcome. And so if someone is skilled and able to support vaginal breech birth, that for me it really is the ultimate litmus test, because it's probably the most difficult thing to support in today's systems. So that's a little bit about where I am today and how I got to where I am. I've been working full-time with Breech Without Borders since 2019, 2020, when I stopped university teaching because it was just too much to try to do both at the same time. And I, run the organization. I do a lot less of the hands-on training now. I used to travel and co-teach quite a bit, but now that we have a huge cohort of instructors, my job is more pedagogy, creating the videos, doing the research, running the organization, all those kinds of things.
Yeah, it's an incredible organization, and the amount of women in the interviews that I've done when I've said what kind of resources Breech Without Borders, like almost every time. So it's amazing. Yeah, it's really, really good. It's a great resource, and it's something I always refer for women's asking about what are my options. That's my first go-to. Go do Breech 101. Go learn as much as you can before you start making decisions. So a big thank you from us as birth workers, midwives, doctors, and the women who need the information. So you manifested very well there, creating that thought and creating it into something real. I did want to ask, how many educators or trainers have you got now in Breech Without Borders?
Yeah, we have close to 20, I think it's 17 or 18. We have one or two more that are just finishing up their training program. And it's lovely because our demand is definitely outstripping our ability to supply instructors, especially in some locations. I mean, even in the US, we have 4 instructors now, and we still can't fit the demand because, many of our instructors are still themselves clinicians and still have their own practices. It's a little bit challenging to fit that in between their schedules. Yeah, it's really nice in terms of being able to offer instruction without having to fly someone halfway across the world every time. So we have 3 or 4 based in Australia, 1 in New Zealand. We have 4 in the US and a couple in South Africa, and then a big cohort in the EU. So that's very exciting.
Amazing. It's so good. I can imagine it's just going to keep going and growing if the demand is there. So, first question I had for you outside of what you've already answered, if you had to share some top tips to parents on the research around breech, what would they be?
Yeah, it would be that there's 5 main areas of risk or safety to consider in terms of when you're weighing the risks and benefits of the 2 biggest options, which are C-section versus a vaginal breech birth. Setting aside ECV for a minute, but if we're just looking at, like, let's say your baby's still breech, either it didn't turn or you didn't choose an ECV, and you're looking at your 2 choices. It's very difficult to give a short answer in terms of, like, which is safer. We want the soundbite answer. And the problem is that each of the 5 areas of medical risk have a different risk-benefit balance. So for short term for the baby, the research is pretty clear that there is a heightened neonatal risk in the short term. There is a higher risk of the baby dying or the baby having some serious injuries, most of which don't persist long term. These are short term morbidities, but they can be severe. The risk is quite low, either with cesarean section or breech birth, but overall, the general pattern is there is a slightly increased risk. The tricky thing with risk counseling is if you just say it's higher or lower, it hides how common it is. And a lot of times women are just told it's more dangerous to have a breech baby vaginally. Your baby's more likely to die, to get injured. And without having the numbers, it's really hard for parents to understand, what does that mean? Like, how much more likely are we talking? 1 out of every 10, 1 out of every 100, 1 out of every 1,000. And so part of what we try to do is translate that into a little more understandable information. If we take a look at, like, the global body of research coming from resource-rich countries, so we used to call it first world, but I think the name is more like resource poor versus resource rich. But, wealthy industrialized countries with good healthcare systems, the kinds of countries that maybe many of the listeners are living in, but maybe not all. But, looking at that research, so a context that's, we're not talking about a place that has no access to cesarean section and is in the middle of famine. We're looking at an estimated risk of the baby dying of somewhere in the neighborhood of 2 per 1,000 in a breech birth versus 0.5 per 1,000 with a cesarean section. And that number is coming out of an estimate that the UK guidelines did. So it's not to say that the risk is totally equivalent, but I think we can say fairly confidently that in countries or in centers that have a high level of skill and training, that risk can be minimized and sometimes erased entirely, even for the baby in the short term. And this comes from some really large multi-center studies from France and Belgium, from a study called Primoda, and there's another one by Venditelli doing largely the same thing, where even in the short term, the outcomes were so close as to not be statistically different in terms of morbidity or mortality for the baby. And so this to me points to the need for skills and training, because we know that we can make it safer, right? We have data that I think is pretty clear on that. So if we know we can make it safer, why are we not making more efforts to make it safer, right? For me, that's a real big imperative, because breech birth continues to happen. We have precipitous undiagnosed breeches that still come in, and we have women who still want it. Interestingly enough, I know this is more of a US relevant topic, but there's a new study out in 2025 looking at all of the breech births in the US at term without fetal anomalies. So it's something like 375,000 breech presentations over a number of years. And, despite, 95% of them had cesarean sections, which is about what's on track with probably what's happening in Australia. Basically the ones that just fall out before they can section them. But what's the risk estimate from the US in a really, really recent study? It's really quite close. So it's about 1 per 1,000 for a cesarean section, the risk of mortality, and about 4 per 1,000 for a vaginal breech birth. In a US context, which means mostly cesareans, but some fall through the cracks, and those that fall through the cracks with probably an assumed not super high level of training and skill, we're still looking at somewhere in that same neighborhood. It's a higher risk for a vaginal breech birth in terms of fetal survival. But it's not what the term breech trials said 25 years ago, which was that it was 3 versus 13 per 1,000. So they found a lot bigger difference in the risk of the baby dying. So that's the one area. So I'm going a little more in detail than maybe you wanted, because I've only gotten through one of the 5, but that's the one that,
No, it's good.
the
It's
biggest
good.
concern to most parents, right? Is my baby going to survive? So I think it's really important to keep that in mind. Yes, there is some difference in most systems, although in highly skilled centers, you can be more confident that there's probably not even a difference once you account for things like fetal anomalies and those sorts of things. But the risk is not quite as high as we had thought from this one study 25 years ago. And that's the study that most obstetricians will continue to quote today. So interestingly enough,
Huh?
can I tell you
Yeah.
an interesting anecdote? So just last week, I flew to the US to testify in a lawsuit about breech birth, and it was primarily a lawsuit about informed consent, where the woman was told that her only option was cesarean section. She wasn't even presented that vaginal birth was even an option, and basically had a cesarean section because of no other options. And in the physician depositions that I read through, there was probably thousands of pages, and I read through the three obstetricians who were of most concern. They all said two of the three had never read the term breech trial. They just remembered talking about it in residency. The third obstetrician said, yeah, I'm pretty sure I read it back, 25 years ago. None of the three had ever read any research articles since the term breech trial. And two of the three had never even read the
Wow.
study. So think in terms of risk counseling. That's the only thing they know about breech, and two of the three hadn't even read it. And this is really typical of most
Mm.
obstetricians. They'd heard about it, they knew there was some study, they couldn't quote anything from it, and they'd not done a single bit of research since. And these are the people who are giving women their information about risks and benefits. It was shocking, but not that surprising at the same time. Physicians are not inherently researchers. They don't really know the medical literature. And most physicians today, it's hearsay from 25 years ago from a study they likely never read. And that's about the extent of the information that they have that they can use to give women informed consent counseling. I mean, how on earth is that informed consent? It can't be considered informed consent because it's not accurate, it's not up to date, and it's not even giving them any sort of information that's at all evidence-based at this point. So that's my little rant about the need to know what the evidence actually says and to stay up to date.
Yeah. And I so often hear women saying they get told, oh, it's high risk. And there's no definition of, like you said, the actual numbers. That's how you make an informed decision. And it sounds with those doctors, it could be quite cultural. It's what I'm hearing in settings as well. It's a cultural practice and nothing's sort of shifting or changing. And it's just that habitual process. Well, this is what we do. So we'll just continue to do it.
Exactly. Yeah. And the same pattern emerges with, in terms of the baby, the risk of having like a severe morbidity, something like a long NICU stay, having to go to cooling, needing assistance breathing, those kinds of things. It's a little more common with the vaginal breech birth, not as common as the term breech trial. And again, it's hard to give an exact number because these are lots of different things that we're lumping together into one category, calling it severe neonatal morbidity. The same pattern emerges. It can be just as low if we're really well trained. It's probably a little bit higher. But the thing is, that's the first of five kind of risk areas in terms of vaginal breech birth versus cesarean. What we find though is that we know that in the long term these risks disappear for the baby, so they even out over time. And this is even carried out in the term breech trial itself. As flawed as that study was, the long-term follow-up with those infants as they reach 2 years old, there was no better chance of surviving or of avoiding a big neurodevelopmental delay if you had a cesarean versus a vaginal birth by the time the babies were 2. So for whatever reason, this big jag in perinatal morbidity and mortality evened itself out over time. Most studies agree on this, that in the long term, the outcomes seem to be equivalent. There's a few that might be slightly skewed in favor of cesarean section for the long term, but most of them show that overall that we're not having like lower test scores, lower academic achievements. We're not having higher rates of cerebral palsy, those sorts of things over time if you compare vaginal birth versus cesarean section. And then the other three main areas of risk, and getting back to, what would you tell parents that they should know, is that there's short-term risk to the mother in the days and weeks following the birth. There's long-term risks to the mother, and then there's the risks to the mother's future pregnancies and future babies. And in all those three areas, maternal risk and long-term risk for the next baby, it's definitely safer to have a vaginal birth than a cesarean section. There's less risk of morbidity and mortality for the mother. It's actually more dangerous for the next baby to be born if the mother had a previous cesarean section. There's more likely that the baby will die either as a stillbirth or during labor. It does affect the next baby's chance of survival. And so those are all the risks and benefits that you have to weigh. You do take on a little bit of extra risk for this baby in this pregnancy if you have a vaginal birth, but you also have the benefit of less risk for yourself and less risk for your future children. And that's a hard risk benefit thing to weigh, right? Knowing that there's no way to avoid the risk. You're either going to take it on some risk now or some risk later. And where do you want to put that risk? And you could still make the choice that you're trying to avoid the risk now, and it still could come to you now. You still could have the 1 in 2,000 case of mortality after a cesarean section, even if you chose a cesarean section or vice versa. So it's hard. I mean, if we could predict outcomes, then we would only have cesareans for those very rare cases where we could predict that they would definitely have died. And then everybody else would have vaginal births, and unfortunately we can't do that. And so we're left just trying to balance the roll of the dice, right? Do we want a small risk of the baby getting injured now, or a small risk of the mother dying or having a severe morbidity? It's those kinds of things we're weighing. And it's hard. You have to live with uncertainty if you're doing this kind of work. I mean, honestly, if you have children, you have to live with uncertainty. I mean, I still have horrible dreams and nightmares about my children dying, and my children are, 12 through 19 years old at this point. I don't think that fear ever leaves you as a parent. And we would like to be able to expect and promise perfection, and we can't. And that's one of the things as a parent you have to somehow accept, that there's going to be uncertainty and there's going to be risk, and there's no way to get rid of risk. Even by choosing cesarean section, you can't. You can maybe minimize some short-term risk for that baby, but you can't get rid of it. You can't guarantee a good outcome. And so you have to kind of adopt an attitude that's, you have to become somewhat tolerant of risk, not to be flippant about it, but to accept that it's there. The fact that we put our children in a car and we drive them is incredibly risky. We're putting their lives in danger every time we put our children in cars, yet most of us do that every day and we don't really think about it. But if we take this kind of holier than thou view, that how dare you put your child's life at risk, by wanting a vaginal birth for your breech baby, as if no one would ever put their child at risk. And yet everybody puts their kids in a car and drives, right? So we're biased about some risks because they seem familiar and they seem controllable and manageable. And again, I don't want to be flippant. I mean, it would be devastating to have a severe morbidity or to lose a child. We don't want that for anybody. It's not to be like, oh, it's not a big deal, but it's a part of life. There's risk, and it's also the fact that that risk comes with benefit and vice versa. And that's the thing that we have to really weigh carefully.
And that's how you make an informed decision, having all that information.
And if you don't know the actual numbers, the actual likelihood of all these risks, how can you actually make a good decision? It's not just saying one thing is more or less dangerous. It's like, how much more dangerous, how much less dangerous. And that's what's really crucial to know. And, if your physician has not even read the term breech trial, let alone not read any literature in the last 25 years, how can you rely on your physician or your midwife to give you that accurate information? I can't really make an informed decision without the information. That's what informed consent means.
Absolutely. So I have a question from one of our listeners. They've asked, what recognized resources can I share with my health team to help make informed choices? So I'm guessing she's coming from a perspective of she's being told to have a cesarean and she wants to try and educate them. You mentioned one before, the promoter study, and then there was another one.
Yeah, a similar study by Venditelli in about the same time period. I mean, that's a good one to look at because it's a lot more reflective about what's happening on the ground versus in this randomized controlled trial that we're never going to repeat the same criteria for, right? I think it's also worth looking at some of the resources we have in many of our different courses. We present like these charts that show these bubble dots of a lot of the biggest research that's come out over the last 25 years, just to show where the more recent risk estimate probably is. I really love the UK breech guidelines. They're very well researched and they have a great overview of the likelihood of X versus Y happening. The French guidelines are actually also fantastic. They have something like 374 references. So to compare that with the American College of Obstetricians and Gynecologists, that's the US guidelines. The US guidelines have 16. I'm sorry, ACOG, you failed us.
And I'm guessing the term breech trial is in that.
Yes, and several of them are either the term breech trial or about the term breech trial. There's only like a small handful of those 16 that are actually breech birth studies. Most of them are about ECV or the term breech trial. It is such a gross neglect of even basic due diligence, ACOG. I'm sorry, you did a terrible job. You put 16 references in your breech birth recommendations, whereas France, which updated theirs in 2020, so about the same time period, ACOG's was updated 2018, France did 374. So get your act together. It's just shocking, the lack of effort they put into that. I'm sorry, but it is pretty shocking. Yeah, so UK breech guidelines are fantastic. The French ones are fantastic. Most of them are in French, but the summary of the French guidelines are written in English, and it's actually a really good overview. They're quite good, in terms of the risks, benefits. They look at maternal, they look at neonatal, long-term, short-term, and just try to give the best available evidence of what the research says. Thing is, it's going to be hard to convince somebody who doesn't want to do it, and who probably doesn't have the training. Right. It's very difficult.
Yeah, can be a bit of an uphill battle.
Yeah.
Next question, is there any new research on breech, like in the last couple of years that you're aware of? I believe you're doing some research?
Yeah, so I do both like secondary research, looking through the literature and summarizing what the literature says. And then I do primary research, so, publishing my own findings. So just as an example, in the last year, there are studies that are directly about breech birth not like ECV and not like hip dysplasia, but like, breech birth outcomes in some way, right? Whether it's provider training and education or, actual outcomes of breech versus cesarean. In 1 year, there's like 87 research articles and about 120, 150 if you look at the wider thing, like including ECV and all the kind of allied things. So we're looking at, probably in the last 25 years since the term breech trial, well over 2,000 studies that are pretty directly relevant to breech birth in some way or another. I mean, there's so much research out there. So there's always things that are emerging and coming out. Our training courses that we have that are part of our hands-on training. So we have online courses that complement our hands-on training, and you can take just the online or you can take online plus hands-on if we are in your area. We are pretty good about having updated research. I'm going to be refilming some shortly because things are always changing and evolving. We've refilmed some other modules recently to integrate that. So yeah, there's a lot of stuff. I do yearly research updates where I summarize what's happened in the last year with breech research and put it together. I have 5 years of booklets that I'm working on right now that they're getting close to being ready from 2021 to 25. And so we're hoping to have those online, both like print version in the US and then PDF version elsewhere. And so that's nice if you're a healthcare practitioner and you want to know kind of what's new in 2025. We're hoping to have those kind of things released soon, where you just have a bibliography organized by topic, and then you have all the abstracts organized by topic, so you can kind of thumb through and see what's there and read through the abstracts. And then if you're interested, then you can hunt down the full text yourself. Yeah, I mean, and again, I think what the research consistently is finding is, there's maternal benefits to having a vaginal birth. There's maternal risk to having C-section. There is some benefit, but the benefits are consistently smaller than we previously thought. And then there's risks to the next baby, and this is true if it's preterm or term. If you have the cesarean section for that first one, you have an elevated risk of adverse maternal outcomes and adverse neonatal outcomes in the next pregnancy after that breech baby. So that's what's kind of emerging in terms of a global level, looking over at all of the vast body of research. Yeah, so I could get more detailed into individual studies, but we'd be here for way too long. But there is quite a bit of stuff, and every year there's more research coming out. Yeah.
I didn't get to be at the Convergence conference last year, but I've spoken to people about what you shared there, and from the breech birth analysis that you've been doing, is it true that from the last tummy crunch, a practitioner should act with maneuvers at a birth?
I talk about the video analysis. That's a really interesting project. So we took a collection of physiologic breech birth videos that are in our library. We have almost 400 now, but at the time, 207 of them met the criteria. So we were looking at a video that showed the whole thing without the camera getting set down, number one, from rumping to birth. So the baby's butt is just starting to come out until the head's born. It has to be singleton, so we excluded the multiples just to be more consistent. And it had to be predominantly upright positions. We have only a small handful of supine breech videos. We thought, let's just look at ones that are considered upright or physiological just to be more consistent. So we had 207. And we had some really interesting findings. In particular, we looked at things like signs of fetal vigor versus signs of fetal compromise. Like what signs can we look at besides listening to the fetal heart rate during expulsion? So when the bum is starting to come out and the head is born, that can give us more information on the baby's well-being, and that can also guide us on when should we intervene and when should we not. And we are the first project to describe gasping, fetal gasping, as an event that happens during a breech birth. So when babies are vigorous, they do what we call tummy crunches, although it's not just with the tummy, it's huge leg lifts and arm lifts, very, very gymnastic. The legs are getting lifted all the way up, and babies are kicking and like doing arm curls, like these really muscular, vigorous looking movements, which anecdotally have become called tummy crunches. So that's what we call them. So those are signs of fetal vigor. And we looked at how often babies did this and how long they did this until they stopped doing it during expulsion, if any. So we timed the kind of the last tummy crunch and at what time did that cease. And then we also timed the first incidence of gasping. And so gasping is, in contrast to a tummy crunch, it's also a fetal movement, but it's when the baby does a short, jerky inward inhalation, like sucking in air in the upper chest, and the chest kind of looks like it's caving in. I don't know if your listeners will all be watching the video. Some might just be listening, but if you're watching a video, it's this almost like sucking in of the upper chest, and the arms sometimes jerk upward really jerky and spasmodically. And it's short and it's like inward and doesn't look at all like tummy crunches. However, because nobody else was talking about gasping until we identified it as a thing, we would hear providers on some of these videos say, oh, look, the baby just did a tummy crunch. Yay. And this baby's gasping. And we're going, oh. One of the reasons we wanted to do this study is to actually say gasping is something that these babies do, and gasping is a sign that baby's entering hypoxia. So from a physiological model, this is what we know from animal research, from human research, like this is, like neonatology textbooks. When a baby's oxygen supply, a fetus in particular, is compromised. So let's say there's cord compression or, a placental abruption or something. Shortly thereafter, the baby does a series of gasps. It's a reaction that's driven by the brainstem to kind of reoxygenate. And so, soon after the oxygen deprivation starts, the baby will gasp. And then if the baby doesn't receive oxygen from that gasping, like if it's still in utero and it can't breathe air, then the baby will have a short period of time where it will stop gasping and stop doing anything. The heart rate will still remain fairly elevated at this point. These are fairly fast process. And then as the oxygen deprivation continues, the baby does another set of gasps. This baby's entering secondary apnea at this point, for those of you who are kind of in the more medical terms. So the first gasp was a sign of primary apnea. Um, and, and then the baby has a period of no gasping, and then it does another series of really deep brainstem driven gasps. It's entering secondary apnea. And if the baby doesn't manage to oxygenate itself, then, like if it's still in utero and its face is not exposed to air, then it enters terminal apnea and it dies. So these are done from like really horrific studies on sheep, where they would do a cesarean section, clamp the cord, keep the baby's face covered, and just see what happened as this baby's oxygen was cut off and what it would do until it died. So it's really morbid, but this is what we know about mammalian physiology. And so if you have oxygen deprivation, the baby has two series of gasping. First, right when it first happens, and second, when it's nearing terminal apnea. It makes another big struggle to survive. As second brainstem driven, like, we're about to die. Let's see if we can oxygenate. And so what we think we see happening in these videos is if you see a baby that comes out and it's doing tummy crunches and then it loses tone and then it gasps, that baby is in primary apnea. And so we call that primary gasping. And it's not good that we see gasping, but that kind of gasping is less concerning than if a baby comes out and you never see a tummy crunch and it's limp and then you see gasping. That might be entering secondary apnea, the gasping that precedes terminal apnea and death. Okay. So the gasping that we see with no evidence of fetal vigor is more concerning because it might very well be secondary gasping, like later on in this process of oxygen deprivation. And in the most worrisome things actually are babies that come out limp and never gasp, because they might have already passed the primary gasping and the secondary gasping. They might be in terminal apnea at that point, right? And this is such important information to know. We found that the average time interval from when babies stopped crunching and started gasping was about 1 minute. A little bit more, but we're saying in terms of clinical teaching, we're saying if you haven't seen a tummy crunch for a minute, you can't say this baby's vigorous anymore. So the tummy crunch is only valid for a minute maximum. So the point is we should be seeing ongoing signs of fetal vigor, like lots of tummy crunches consistently, not every single second, but the baby should be continuously showing you that it's vigorous. And if it's not, then you can't assume that baby's vigorous. And if you ever see gasping, if you ever see a limp baby, or if the baby stops to do a tummy crunch and it's been more than a minute since you took a crunch, that baby can't be considered vigorous. And that's an indication to expedite the birth. And the first things we say is have the mom push harder, right? Big maternal pushing efforts, big maternal position changes, maternal movement. Those are your first things that you can try. And many times that will expedite the birth enough to make it happen. If those don't work, then you move on to things like fundal pressure. You're adding extra power to the maternal contractions or maternal pushing efforts. You might not have a lot of contractions at the end because the uterus is emptying out and you can't assume the contractions are going to push the baby down at the end. But you can boost the pushing efforts from above by using fundal pressure, which is safer than pulling the baby out from below. And then, of course, you can also do the normal maneuvers. If there's an arm stuck or a head that needs flexing, you can do maneuvers on top of that if you need to assist. But the point is that babies give us some really clear signs of when they're doing well and when they're not doing well, that we can observe with our own eyes, that are more important than the fetal heart rate. Because at least from what the animal studies and what we know about physiology say in general with fetal compromise, the heart rate isn't affected immediately. You have the gasping before the heart rate is affected sometimes. And so these are signs that might precede the fetal heart rate showing a change. And so it's just something to be aware of is the heart rate during expulsion is kind of secondary, because everything you need to know is going to be shown to you right in front of your eyes with the baby's lack of muscle tone or overabundance of muscle tone, right? And whether it's gasping or not, that's more important than trying to track down a heart rate, because what is it going to tell you? Either the heart rate's going to be fine, but if you have a heart rate that's fine in a limp baby, I don't care. the limp baby supersedes a good heart rate. We tell people just look right at fetal condition once rumping happens. It's way more important than trying to track down the fetal heart rate because it'll tell you what you need to know. But that's the answer of our video analysis. We have a lot of other things we looked up, but that's probably the most important things that we found. Another thing that we found that was really interesting is about 1 out of every 6 breech births has a placenta that detaches early. So that's either meaning the placenta is literally born right after the baby's head, or there's clinical signs of placental detachment with what's called a separation gush. Bright red blood that's really copious that comes out right with the head that's not associated with the perineal laceration, where you suspect that this is the gush announcing the separation of the placenta. And we found out in about 1 out of every 6 births, this happened. You don't know it's happening usually until after the fact, but this also explains why breech babies are shockier at 1 minute, why they do have lower 1 minute apgars in these births where the placenta separates early because the uterus starts to empty itself out towards the top as the baby is so low. The uterus thinks the baby's born. It doesn't always know there's a baby way down low in the pelvis because the uterus is still quite a bit higher. So it just starts to do the next thing, starts to release the placenta when it senses that it's not full anymore. With a breech birth, you can still have a baby halfway in and the uterus thinking that it needs to get the placenta out because the baby's out. Our bodies are interesting that way. They don't always get the memo that there might still be a head in the pelvis quite deep down. So this also lets us know, like, this is why we want to avoid overly long expulsive stages, because we did some statistical calculations and placental separation is statistically correlated with longer expulsive stages. And it was a pretty strong p-value. And early placental separation is correlated with lower 1 and 5 minute APGAR scores. So we know that if it's a longer birth, it's more likely to have placenta detaching. And we know also that the longer births are likely to have lower APGAR scores. So we just want to keep things flowing. That's the point, is keep things moving. Don't have any long delays. Something should always be moving and happening. And then if there's any signs of fetal compromise, the baby's limp or gasping, you get that baby out as quickly as you can, right? You don't wait. Because if you see a baby that's clearly compromised, it's not going to get any better. So there's no reason to wait and say, oh, wait for the next contraction, take some deep breaths, take a rest. No, it's like you have the mom and roar that baby out and, squat and move, and you might do your maneuvers or some fundal pressure, whatever you need to do. But you have to be really smart and not look at it. Don't sit there and watch a baby that's struggling in front of your eyes. We've seen too many videos of providers doing that, frankly, because they're like, well, hands off the breech. That's not always the case. Sometimes your breech babies need some motivation.
Yeah, and I also think time just disappears when you're in that space as well. So important to have a timekeeper or your second or someone is monitoring the time to really keep track of that.
Yeah, yeah. And there's no perfect time. Like, you can't say every baby, if it's born within 3 minutes or 5 minutes, will be fine. Some babies are horrible and they're out within 1 minute because they were already starting to get compromised prior. So this means, like, before rumping happens, when you can see the legs, you have to monitor the heart rate really carefully and really frequently, because you can have very quick extreme or acute cord compression happen, or a placental that starts to detach. And if you're not picking up heart tones very, very often, you're going to miss it. You can have a baby that goes from perfect to completely flat in like 3 or 4 minutes if you have completely acute cord compression. So be really smart, really listening carefully to those babies before rumping, and then after rumping, just monitor the signs that you see in front of your eyes and act accordingly. Just don't watch a baby sit there and do nothing and suffer in front of your eyes. That's the message we want to get across.
Yeah. Awesome. Thank you. Another question. So what advocacy recommendations would you suggest to women with breech babies or those working with women?
Yeah, I think that hospitals need to keep getting consistent, repetitive, clear messages from many, many women. We want breech birth options. We want you to be trained. We are not going to accept a routine cesarean section. 3 to 4% of babies are breech, and so it only affects a small subset of the population, but you often don't know it's breech until the end, right? And it's time sensitive, it's limited in scope. So I think being really clear about consistently communicating to the hospitals, writing letters up the chain of command, like from anywhere to head of obstetrics, head of midwifery, and then their supervisors, all the administrative people, the risk management, the president of the hospital. They need to hear from the consumers over and over again. Like, we want these options. We're not going to put up with being forced to have a cesarean section. Enough that they feel like, oh, we should do something about this. I think that's one really important thing, is hearing it from the consumers who can put pressure on the systems to provide the choices that they feel that they want. If they don't, what's the motivation to change, right? A cesarean section is perceived as safer for the provider, not necessarily for the mother. It's easier, it's faster, it's predictable. Vaginal breech birth isn't. It takes a long time. It's chaotic. It's unpredictable. Those things all build fear and reluctance, right, to understand the process. So, consistently communicating to both individual providers, but also the hospital system level. We want these options. We want them in our system. We don't want to have to go, have an unassisted birth or have to go outside the system. I mean, it's ridiculous how many women have to relocate, travel. I mean, we shouldn't have to rent an Airbnb out of state or out of country just to use our own vaginas, right? It really shouldn't be that hard.
Yeah, perfectly put. I love it.
And I love home birth. I had all my babies at home. But a lot of women aren't willing to choose a home birth, especially for their breech baby, and they deserve safe options and physiologic options in a hospital setting. I think, at least in Australia, Andrew Bissett's, I was talking with him, he believes strongly that midwives need to lead the hospital breech revolution. I mean, because he's like, most obstetricians just don't want to touch breech. He's like, fine, have the midwives do it. So he thinks midwives need to be the ones leading the breech clinics and the breech services because they're the ones who want to do it and they're eager and they have the skills to support physiologic birth and they're really keen and motivated. So I think that's the model that we hopefully will see in the future. It's just very hard because there's so many systemic level things and barriers to overcome. But hopefully that's the direction it can go.
I am seeing in other midwives, there's fear there, and it's fear about being reported, which comes back to what you're saying about the obstetricians, fear of losing your job, being reported, having no income to support your family. It's a very fine line to try and walk that path with a woman and then also protect yourself as well. So it is ideal if we can get it implemented in a hospital setting. But yeah, I think in an ideal world, I know it's happening in other countries, but in Australia, I would love it to be more midwives stepping up and saying yes to support women and being supported by our governing bodies. So I feel like you've already answered. A question from one of the listeners was, what can we do at a local level to help change our public system? So she's actually shared that she recently volunteered as a consumer representative for her local hospital to try and help facilitate change in maternity care. So that's something else that women could consider. I'm not sure exactly how they go about that, but that is something, if you've got the capacity to take on. I guess her question around that was just sort of practical statistics and questions would be really useful on bringing to that level, how she can implement that. I guess that's probably coming back to the research and that push and petitions, maybe getting women to sign petitions to show the numbers in the area to get noticed.
Yeah.
Is there anything you'd add to that?
You could ask Breech Without Borders. We do a lot of virtual lectures and grand rounds sorts of things where we present information and research to hospitals. And it's often the first step in them wanting to start training their staff. Because we can present, like, what does the recent research say? Like the 5 areas of safety I talked about. I have a lecture that we do that, about that. How does breech birth actually work? And so if you have at least enough interest that they're willing to have someone come and do a virtual lecture or in person if we happen to be in your area, that's a really great way because it's not all at once, right? It's just an hour lecture and that's usually pretty interesting. So that's another thing you could do is invite us to come.
Yeah, that's good to know. I think that'd be really good for any midwives and obstetricians listening that are working in that setting that want to create that in their workspace, that they could get a virtual presentation. So that's good. Great. Thank you. What's the research say about breech water births in comparison to breech land births? Is there any research, I should say first?
Not really specifically about breech water birth. I know that Cornelia Enning, I believe, was a German midwife, did a lot of breech water births. But I don't think she ever published information in terms of her statistics and outcomes. We know another midwife in the US who died a few years ago who did over 600 breeches in her career, and most of them were water births. Felt like they went really, really well in water, but we don't have any research studies, and I think that'd be an amazing project to have. We would need to have someone with a high volume of breeches and a high volume of water breeches that we could actually have something useful for. I know that the feeling is that if you're really comfortable with breech, then yeah, sure, give it a try. You can always get out of the pool. I know those who are newer to breech might say, hey, would you be willing to get out right when the baby's bum is starting to emerge? Because it's easier to visualize the baby and it's easier to do maneuvers when you're not in the middle of a pool. And that might be a really reasonable choice. Like, use the tub for the whole labor. You can use it for most of pushing. Would you be willing to stand up and just get out at the very, very end, especially if you're newer? I think that the feeling is for those who've done breech water births, they tend to go really lovely and they're amazing births. But sometimes the water does get in the way in terms of visualizing the baby and also in terms of doing maneuvers. But yeah, unfortunately, we don't have any good research on that topic. That's enough that we can say, and here's outcomes of water birth versus land birth. That would be super amazing to have, though.
Yeah, it would, definitely. It's no different to shoulder dystocia. Like, a head could birth, and you're in the water and go, all right, actually, no, we need to get out. A woman will do incredible things when you stress that it's time to get out.
Totally, yeah. Yeah, and it's harder to evaluate the tone. I just wanted to say with a water birth, when you're in water, even if the baby's totally limp, it can look like it has a little bit of a tone and flexion because it's floating in water, and the limbs of the baby don't naturally straighten all the way. They naturally have some bend to them. So you can think you have a baby that's maybe even moving and that has tone, and that's completely limp and floppy because the water supports it and it just looks like it's holding itself in somewhat of flexions. That's where it's really tricky to evaluate tone. Tummy crunches in a water birth have to be completely unmistakable. And so, yeah, it's just harder to evaluate the fetal condition sometimes. Sorry to sidetrack there a
Yeah.
little bit.
No, that's good. Yeah. Is breech more likely to happen again after a woman has had one breech baby?
Yeah, if you had a breech baby, you're more likely to have breech the next time around, and I think that kind of goes up. So sometimes we think some of that's related to if you have a uterine anomaly, like bicornuate, unicornuate
Hmm.
uterus, something that predisposes the baby to fitting better breech than it does head down. And some of it's also genetic. There's something about breech presentation that runs genetically in families and not necessarily just female to female. Like it also is passed down through the male line. So it's somewhat of a very interesting history. But yeah, if you've had one, you're more likely to have another. And so if you've already had one breech baby, you want to be extra careful to seek out breech options early on in your pregnancy because it might be more likely to happen again. Someone has tracked the incident somewhere, and if you've had one, it's an incident. The likelihood of it occurring again is like 10% versus 4. I can't remember exactly, but it goes up. It's definitely a higher likelihood.
Yeah. I always find it very interesting when they say, "Oh, I was breech," or "Dad was breech." Like, yeah, just wondering what's going on there. It's very fascinating. So you mentioned bicornuate uterus or uterine anomalies. Do you have much knowledge about them and why women are, I guess, deterred from having a vaginal birth when their baby is breech?
What we know is that it does predispose you to having a breech presentation with these uterine anomalies. But if you can get past the prenatal risks, which are premature labor, that sort of thing, if you're full term, there's no reason that the uterine anomaly would get in the way of having a vaginal birth, whether the baby's head down or not. But the one exception could be, and this is quoting from some of our instructors because people have asked them questions, so I have some email correspondence. So if you don't have miscarriage or preterm birth, all the things that happen before the labor actually starts, then it should not be a problem. The other thing is if you have like a band of tissue remaining below where the horns join together, like if you have a septum that might get in the way of the birth, um, you can have that looked at before the labor starts and such, but that's more really unusual situation. But a septum really quite low down may get in the way. But if it's just a bicornuate or unicornuate uterus, that should have no bearing on the labor or birth itself. It just does predispose your baby to not turning cephalic as often. It doesn't seem to impact the uterus's ability to contract and dilate and do all the things it should. So again, that's not a contraindication to having a vaginal breech birth. And it's in none of the obstetric guidelines. They don't even mention that as a contraindication. So it's, again, you just have to make it through the challenges that you might encounter prenatally in terms of preterm birth or miscarriage, or even difficulty conceiving in some of these anomalies.
Yeah. I've just recently been reading the research around this, but I can only get access to the abstracts, so I don't get to actually analyze it. And there's a couple mentioning that they found these women tend to develop gestational hypertension and preeclampsia, which I just can't help but think, is that potentially just something else and really nothing to do with the bicornuate uterus? Do you know anything about that?
You mean preeclampsia in uterine anomalies specifically? Huh.
Yeah, yeah.
I don't know about that. I do know that the overall rate of like gestational hypertension and preeclampsia, I have a study open right now in front of me, like a big national registry study, doesn't seem to be different between breech and head down. Some things are, like you're more likely to have oligohydramnios if the baby's breech than if the baby's head down. Like some things more likely to have premature rupture of membranes if it's breech versus head down. But things like, at least in this study, like gestational diabetes, pregestational diabetes, hypertension, those are all almost identical between the two things. So, but whether there's an association between uterine anomalies specifically and preeclampsia, I don't know. And I don't have that information here because they weren't doing those cross comparisons.
Yeah.
Yeah.
It was very odd. I just don't understand how that can be associated, just thrown in there as another risk factor on the list of things for women. I've interviewed a couple of women with bicornuate uterus. They've had a few breech and they're wanting to know what are the risks, what's the actual issue. And it seems to be a lot of the time the issue is that babies breech and not actually the fact that they have a uterine anomaly. One question from one of the listeners is prolonged rupture of membranes more common in breech presentation?
Yeah, it's about at least in this one study, and looking, it's a large national registry study, so looking at nationwide data, about 3.4% of the breeches had PROM, and about 1.9% of the head down babies. So it's a little more common. Yeah. Not massively so, not 50%, but 1.9 versus 3.4.
Yeah, great. Is cord prolapse in breech a problem like it is in a cephalic birth?
It's a little bit of a complex question because it depends on the kind of breech a little bit. It's slightly more common in a breech birth than in a head down birth. We estimate a head down birth is, it ranges, but it's 0 point something percent in the single digits, right? 0.3% to 0 point something percent. Whereas with breech birth, it's slightly about over 1% overall, depending on the study you look at, right? So it's a little bit more common overall with breech versus head down, not massively so, but if you look at just at the breeches, it's in a frank breech, it's super rare for the cord to prolapse. It's almost as rare as a head down baby because it's a nice seal. This nice round butt makes a nice cork or a plug, right? So there's not a lot of loose spaces for a cord to slip down in, just like with the head. But when you have a non-frank breech, so complete, incomplete, etc., prolapse is relatively common. The most recent French data estimates that around 5 or 6% of the time you will have a cord prolapse in a non-frank breech. What's interesting, though, is from this one study that a German colleague of mine helped me translate it from German into English. They studied all of the cord prolapses in their institution over 12 years and looked at in detail what happened and categorized them by type of breech presentation and also looked at the cephalic prolapses. So the non-frank breech prolapses were more common in their institution. Around 10% of all the non-franks had a prolapse, 10 or 11%. But they actually did a lot better than a frank breech prolapse or a head down prolapse. So this was back in 1980.
Yeah.
So about 1/3 of all the head down prolapses died and 1/3 of all of the frank breech cord prolapses died. These are small numbers, but it's over their whole institution over a long time span. But of all of the prolapses that happened with the non-frank breeches, none of them died. And their APGAR scores weren't time dependent like the frank breech prolapses were and like the cephalic prolapses were. So with a frank breech or cephalic, the longer it took to get the baby born from diagnosis to delivery, the worse the APGAR scores tended to be. Whereas with a non-frank, that didn't really seem to affect it. Given the longest time period was something like 45 to 60 minutes from diagnosis to delivery, whether it was vaginal delivery or cesarean section. So I think the point we can take away is that it's more likely to happen if your baby is not frank, but it's less of an urgent situation than it is if it's frank breech because there's looser pockets in the lower uterine segment. So even if there's a prolapse, that doesn't necessarily mean the cord is getting compressed at all. And if it's not getting compressed, then the prolapse is kind of clinically not significant. Now it's going to freak people out. And in a setting, our setting, we're not going to sit around for 15 hours with a cord prolapse hanging out, even if the baby's heart tones are fine, because it would just kind of be a no-go. But we do know from the experience of our clinicians who work in the field where they're not doing cesarean sections except for maternal indications. So like, in a refugee camp in Sudan or in Bangladesh or something, some of our clinicians have had, preterm cord prolapses for 17 hours that didn't affect the fetal heart rate at all. And they just waited for the cervix to dilate and had a vaginal birth. So we know it's possible. You just don't want to be flippant with it, right? But I think the takeaway is that if you have a cord prolapse in a frank breech, treat it like a head down cord prolapse. So you elevate the presenting part, rush off, and get that baby born as soon as possible. If it's a non-frank, if the birth is imminent and the heart tones aren't affected, then just have a vaginal birth, because why have a cesarean section if she's almost having her baby anyway, and if the heart tones aren't affected? So just be sensible, right? If it happens at 3-4 centimeters in a primip, in a non-frank breech, probably you're not going to have a vaginal birth, even if the heart tones aren't affected, just because in our setting, that's not considered very reasonable. But, if it's a multip and she's already pushing and you see a cord start to come in advance or with the presenting part and heart tones still remain fine, then just have the baby. So I think that's where the being sensible comes in. Just a prolapse doesn't necessarily mean that the baby's going to die and have the oxygen shut off if it's non-frank and if it's near the birth anyway. And just listen to the heart tones and see if it's affected. But, just be smart about it. Listen really carefully, and if the birth is happening, then it's happening. So that's what the research says, at least.
Great. Thank you. What are the risks a woman needs to consider if she's wanting a VBAC versus a repeat cesarean?
And is this if it's a breech VBAC specifically or just a VBAC in general?
This is one of the listener questions. So she's had a cesarean and now she's working out, do I have a VBAC? So it's probably not specific to whether it's head down or breech. But if there's differences there, then please do share.
Well, for what we know, if it's a breech VBAC, so like a breech, with a previous cesarean section, it doesn't seem to have any worse outcomes than a normal VBAC. So you have your breech risks, right, that we talked about. And then you have your VBAC risks, and they don't really influence each other. So it's not like they multiply. They're separate risks. One doesn't make the other riskier. You just have separate risks that are separate things. So whether this is a breech VBAC or just a VBAC in general, VBAC comes with risks and benefits, just like breech. You have a slightly higher risk of something like a uterine rupture happening if you wait and have labor and, push a baby out. And of those uterine ruptures, a very small percent will have a really poor outcome. Most ruptures don't. Most ruptures are clinically insignificant, non-consequential, right? Like, but some do. So you have to weigh that, like estimated one in 200 for a VBAC generally for the risk of a uterine rupture, right? And then of those ruptures, how many of them end adversely? So I don't have the VBAC numbers off the top of my head. So you have that versus, the risks of the morbidity from the cesarean section, the fact that every repeat cesarean becomes more and more dangerous for the mother. You have a lot higher likelihood of developing placenta accreta disorders, of having adhesions that might mess up something, or placenta previa. So if you have a lot of repeat cesarean sections, it gets really dangerous for the mother, versus if you have a VBAC, then those VBACs are safer and safer for the mother each time around. So you just have to weigh that. There's some really good information in organizations called like VBAC Facts, for example, that does research on getting you all those lovely numbers for VBAC like we do for Breech, in terms of what if it's your first VBAC? What if it's a VBAC after 2 C-sections or 3 C-sections? What is the likelihood of uterine rupture for different situations, different kinds of incisions? But if you have a low transverse incision, which is the most common type, if your cesarean section was done at or near term, not extremely preterm, there's a lot of pretty good evidence out there, and the likelihood of success is quite high. So most VBAC attempts, like in hospital, the success rate is a little bit lower, but in an out of hospital setting, it's consistently like 87 to 90% success rate. So if you go into labor, most of the births happen successfully. A little bit lower in a hospital setting, because that's true for head down births or normal births. Home birth
Yep.
tends to have a higher success rate, even among similarly low risk women. It's just, hospitals have a higher rate of intervention for similar populations. But so it's again that risk benefit, slightly increased risk to the baby, but increased risk to the mother, and, balancing those two things out. It's definitely a reasonable option for most women. I don't know how hard it is to access VBAC in Australia. It can be touch and go in the US. Some hospitals support it. It's no problem at all. And then in some areas, they have complete bans and you just can't access VBAC anywhere. So it can really vary widely from city to city or hospital to hospital.
Yeah. I know we don't have bans.
Okay.
It's something that should be offered. What I commonly hear is they get told, yeah, you can do that. And then it's near the end that they start to state things, or it's a bit risky, or your baby's looking a bit big. And then they start to sort of just put those little slices of fear, and then it turns into, oh, maybe we should just induce, or maybe we should just have a cesarean. Yeah.
Yep. Yeah. I'm working on a paper with some co-authors about VBAC after 2 Cs, which is a little bit less research because it's less common.
Great.
Interestingly enough, they had one uterine rupture in VBAC, but they actually had another uterine rupture at 34 weeks with a planned cesarean section. Risk of uterine rupture doesn't always happen when you go into labor. It sometimes happens out of the blue, even before you're in labor. Whether or not you're going to plan a C-section or a vaginal birth. But even with a VBAC after 2 Cs, the risk of uterine rupture isn't significantly higher, as far as we know, than it is after 1. Maybe a little bit, but not significantly. So it can still be a reasonable option for many, if not most women, if they're motivated.
Is there much research already for women who have had 2 cesareans or more?
Like I said, there is some, but less, especially as you get to the higher order, after 3, 4, 5. Because the numbers are so small. Yeah, but there is research out there, and I think we have some pretty good information.
Awesome. That's all the questions that I had. Have you had a breech baby yourself?
No, none that were breech when I went into labor, although my son, my second, was breech for a couple weeks during pregnancy, just by palpation, Leopold's maneuvers. And it was really stressful. At that time, I wasn't completely specialized in breech research, but, I already was keeping my eye on some of the stuff. So it was kind of like a small side interest academically. So I say I probably knew a little bit more about breech than your average person. And it was really stressful. My midwife was very supportive, but herself hadn't attended very many, although she had trained as much as she could. And she's like, Rixa, I will not abandon you, but I don't have a lot of experience. So you have to kind of keep that in mind. I looked at driving 10 hours down to the farm in Tennessee where Ina May Gaskin was located.
Yeah.
I didn't think I'd make it because my first labor was 10 hours start to finish. I was like, there's no way I would be able to do a 10-hour drive in labor. All my labors got quicker, seems to be the pattern. So, there was no hospital options in my area at all. And I tried to make him turn and do all these things. I knew I shouldn't, but I still did. I still stressed about it. And, if I could look back, I should have been just like, don't do anything to even change it. Just chill, because it just stressed me out and didn't do any good anyway. And then he just turned on his own. But even that small slice of those few weeks where it was so stressful and I kept treating it like a big problem, understandably so, because it is in the terms of not having support and not having good options. But it was, it gave me a very small look into what women go through, even though, mine resolved on its own and I didn't have to fret about it anymore. But yeah, it was really stressful. And I wish I'd
Yeah.
just left him be, gestated in peace for those few weeks.
He worked it out anyway. It was good to hear your insight around having that experience, just that alone of the stress and the ideas of the travel and what that looks like. Yeah. Just to give perspective to those who haven't had that experience and don't realise that that is the reality for a lot of women with a breech baby if they can't find a care provider.
Yeah. Yeah, you feel completely abandoned. Yeah, you might have a supportive midwife who's done maybe 3 or 4, or you have a hospital that's gonna force you into a C-section, and, if you try to have a vaginal birth in that hospital, it's gonna be really traumatic, and they might really they might make it quite dangerous for you. It's a really set of horrible
Yeah.
options to be facing, and that's why, I love home birth. I've had all my babies at home, but I want breech birth to be a viable option in, every major hospital at a minimum. Like, in at least every city, there should be a place that does 24/7 physiologic breech. I mean, because if not, we're pushing women out of the
Absolutely.
system and making it a lot more dangerous for them. Women deserve to have good options without having to leave the system.
Yeah.
Yeah.
Completely agree. Amazing. Well, it's been so good chatting with you. Thank you for your time and sharing all the wisdom you have and answering the listeners' questions and my questions.
Yeah, you're so welcome. It's been a pleasure.
The Breech Birth podcast is independently created and produced. If you'd like to support the continuation of this space, you can do so through Buy Me a Coffee. Your support helps keep these stories being shared and accessible to women and families around the world, and you can find the link in the show notes. Thank you for listening to the Breech Birth podcast. These stories matter. They stretch what we think we know and bring voice to experiences that need to be heard. I'm so grateful to our guests who have shared their experiences with us, raw, real, and full of wisdom. If this episode resonated with you, please subscribe and share with others. You can find us on Instagram, Facebook, and YouTube at Breech Birth Podcast. And if you have a breech story to share, I'd love to hear from you. Until next time, may we continue to reclaim the narrative, one story at a time.